Welcome to another explainer. I'm your lead instructor, Harshal. Before we get started, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we are going to look at how a single alphanumeric code isn't just a clinical number on a chart, but the actual, literal, financial lifeblood of a hospital. We're pulling way back on the curtain to reveal the MS-DRG system. If you've ever wondered how medical documentation directly translates into facility reimbursement, or why a single missing word from a physician can cost a hospital $10,000 in a split second, well, you are in exactly the right place. Let's get into it.
Here is our roadmap for today's explainer. We're going to cover the DRG system basics, the MS-DRG architecture, the massive power of CCs and MCCs, sepsis and respiratory coding, ICD-10 PCS and obstetrics, and finally we'll wrap up with some crucial key takeaways.
All right, part 1, the DRG system explained. To really master this machinery, we first have to understand what exactly we are building and why it even exists.
So, what is a DRG? It stands for Diagnosis-Related Group, and you can think of it as a massive statistical sorting hat. It takes every single inpatient stay and groups it with other stays that have similar clinical characteristics and need a similar amount of hospital resources. Crucially, this DRG forms the absolute foundation of the inpatient prospective payment system used by Medicare. Now, the word prospective is the absolute key here. It means the payment amount is essentially fixed based on this specific code before the patient even leaves the building.
It's actually fascinating to look back at how this whole system evolved. It started way back in the 1980s with Yale University's original concept, which basically just grouped cases by primary diagnosis. Over time, state Medicaid programs expanded this into AP-DRGs and AP-DRGs to include more refined data, plus a 4-level severity scale. And that brings us to today's standard used by CMS, the Medicare Severity DRG, or MS-DRG system. Introduced in 2008, this system strictly differentiates your reimbursement by the actual severity of the patient's illness and their comorbidities.
Okay, let's move on to part 2. Let's lift the hood and see the engine at work with the MS-DRG architecture and logic.
Think of the MS-DRG grouper as this massive, complex logic engine, and like any engine, it needs precise fuel to function, right? The primary fuel here consists of your ICD-10 diagnosis and procedure codes, but it doesn't stop there. It also factors in patient demographics like age and sex, the discharge disposition, meaning did they go home or did they go to a skilled nursing facility, and the present on admission, or POA, indicators. All of these distinct data points feed into the software to spit out the final relative weight and payment amount.
The real magic happens in this 5-step grouping logic. First, the engine identifies the principal diagnosis. That's what drives the base major diagnostic category. Next, it scans all the secondary diagnosis. Then, it does something really important. It partitions the cases into either medical or surgical DRGs, entirely depending on whether a major operating room procedure was performed. After tweaking for demographics, it assigns that final MS-DRG. And keep in mind, a surgical case is almost always going to group differently and pay differently than a purely medical case.
Now that we know how the base is built, let's dive into part 3. This is the most impactful variable in this entire system, the severity adjustments. Literally, this is where clinical documentation turns into revenue.
Secondary diagnoses are mapped to a massive list of over 14,000 codes, and this creates 3 very distinct payment tiers for almost every base MS-DRG, based entirely on patient severity. We have a CC, or complication and comorbidity. That's a secondary diagnosis that increases resource use and adds a moderate weight to the DRG. Then, we have an MCC, or major complication and comorbidity. This represents a highly significant diagnosis that adds a lot of weight and triggers the highest possible reimbursement tier.
Let me show you a real-world example of how progressive this cause and effect can be. Take a pneumonia case. If a patient is admitted for simple pneumonia with absolutely no other documented issues, the hospital just gets the base DRG weight. But if the provider properly documents that the patient also has diabetes with complications, which counts as a CC, the hospital gets a moderate weight increase. Now, if that same pneumonia patient comes in and the provider explicitly documents septic shock, an MCC, boom, the case is pushed into the highest tier, yielding maximum reimbursement to cover the intense resources required to save that patient's life.
But wait, there is a massive catch here. Look at how the present on admission, or POA indicator, completely changes the game. Let's say a patient is admitted and later develops an acute DVT. Now technically that's an MCC. However, because it happened after admission, the POA indicator flags it as a hospital-acquired condition, or HAC. Under CMS rules, this completely drops your payment tier. You cannot use a complication that the hospital caused to artificially inflate the DRG payment. It's a pretty brilliant quality control measure built right into the coding logic, don't you think?
All right, part 4. Let's apply this machinery to some of the trickiest and most heavily audited clinical documentation areas out there, starting with sepsis and respiratory failure.
Getting the sequence right for a sepsis admission is absolutely paramount. No joke. It is very often the difference between a compliant, fully reimbursed claim and a massive audit penalty for your facility.
You see, you can't just throw codes on a claim and hope for the best. It's literally a chain reaction. First, you must sequence the underlying infection, say a UTI or pneumonia. That is followed by the code for severe sepsis, if it applies. And finally, you code the specific organ dysfunction, like acute kidney failure or acute respiratory failure. If sepsis is present on admission and is the primary reason for the stay, it takes the principal diagnosis slot, which drives the entire DRG.
Clinical documentation integrity is everything here. Listen, vague terms are the absolute enemy of accurate DRGs. If a doctor just writes down urosepsis, a coder must query them to clarify, do they mean a localized UTI or actual systemic sepsis? Similarly, bacteremia just means there's bacteria in the blood. It does not automatically mean systemic sepsis. And here is a golden rule to remember. Never ever code severe sepsis unless the provider explicitly links both the infection and the resulting organ dysfunction right there in their notes. We need that exact same precision for acute respiratory failure. Specificity is everything. Is it acute? Is it chronic? Is it acute on chronic? Furthermore, documenting the exact duration of mechanical ventilation is absolutely critical. Here is a detail you cannot miss. If mechanical ventilation crosses that 96-hour threshold, it shifts the entire procedure code. This often triggers a major complication classification and a significantly higher DRG weight to cover that extended, very expensive ICU care.
Moving away from diagnoses for a moment, let's shift our focus to Part 5, procedural precision with the ICD-10 PCS system. And we'll use the unique obstetrics section as our prime example here.
What's really interesting is that every single inpatient procedure code in the US is built exactly like a 7-character alphanumeric formula. It's incredibly logical. You build the code character by character: section, body system, root operation, body part, approach, device, and finally, the qualifier.
Now, when we look at obstetrics, there is a golden rule. This section always starts with the character 1, and it strictly applies to procedures performed on the products of conception. We are talking about the zygote, embryo, fetus, amnion, umbilical cord, or placenta. If a procedure is performed on the mother's body specifically, you don't code it here, you code it in the medical and surgical section.
Let's actually decode a normal, spontaneous vaginal delivery using this formula. It's kind of like cracking a safe. So the code is 10E0XZ. Z. Let's break it down. Section 1 stands for obstetrics. System 0 is for pregnancy. Root operation E means delivery. The body part is 0, representing the products of conception. The approach is X, meaning external. And since there are no devices or specific qualifiers used in a completely natural delivery, the last 2 characters are just Z and Z. And there you have it, one single code that perfectly describes the entire procedural event.
Finally, let's move to Part 6. Let's wrap up this explainer by consolidating all these mechanics into some actionable key takeaways for you and your clinical documentation teams.
When you're dealing with complex, overlapping conditions, always cross-verify your primary conditions against laboratory evidence. Take a look at the breakdown of kidney conditions here. You must ensure that acute conditions, like an acute kidney injury, are prioritized and sequenced correctly over chronic stages like CKD, assuming the acute condition is the primary reason for admission. So if an AKI is superimposed on CKD stage 4, you code that acute deterioration first.
So here are your non-negotiable coding and documentation habits required to ensure accurate grouping. 1. You must query providers to confirm vague terminology. 2. Properly sequence infections to their resulting organ failures. 3. Strictly and accurately capture present on admission indicators to avoid unnecessary quality penalties. And 4. Meticulously track things like mechanical ventilation durations.
I'm going to leave you with this one provocative question to take back to your facility. Is vague documentation costing you right now? The DRG system is perfectly logical, but it only works with the fuel it's given. Accuracy equals appropriate reimbursement, while vagueness simply equals lost revenue, compliance risk, and an incomplete picture of patient care. Always strive for that complete clinical picture. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding those charts, and I'll see you next time.